Hello, welcome everyone. My name is Trina Becker and this is Beth Bergstrom, and we are your speech therapy PD presenters for tonight's EPIC case study on developmental trauma. Before we get started with the presentation, there are a few items that I need to alert you to. This course is 60 minutes and it'll be offered for 0.1 ASHA CEUs. Our disclosures for this evening, our financial disclosures for this course include intellectual property rights and royalties from products sold on the B&B SLP Teachers Pay Teachers store and our bbboutique.slp website. We do not have any relevant non-financial relationships to disclose for tonight's course. That concludes our introductory material, so we're ready to start. As I mentioned, I'm Trina Becker, and this is Beth Bergstrom. We both teach at Eastern Illinois University. We're instructors and clinical supervisors in the Department of Communication Disorders and Sciences. We both love to share our passion about our profession through presentations, social media, and through creating resources for SLPs. As I said, tonight we'll be presenting on developmental trauma. Our EPIC case is on Andrew. So our learning objectives for this evening, the first one is to critically analyze case history and other information to determine the etiology or underlying factors or symptoms. Develop a profile of strengths, needs, and functional impact to determine treatment priorities. And the last learning objective is to determine most effective treatment approach using client values, clinical judgment, and research. You have as a handout our guide for client-specific intervention. So this is our EPIC worksheet. This came from the ICF model from ASHA. And so we use that to help put this together for our EPIC cases. Tonight, we're going to talk through developmental trauma. Our client is Andrew. He is 8 years, 6 months, and he came to our university clinic with a complaint of behavior problems due to dysregulation and impulsivity. We were suspecting developmental trauma when Andrew came to our clinic, and so one of the first things we do is look for specific things in the case history. So we've developed this case history checklist to help us identify adverse childhood experiences or anything that's ongoing in the child's life. So we are working on putting this together in a resource, so this is just a sample for now. There you can see we look for some dysregulated behaviors and some inconsistencies also in progress that could be an indicator of adverse childhood experiences. And finally, sometimes when a client doesn't have a clear diagnosis, we can suspect also developmental trauma.
Yeah, and these are all things that are reported. We also really think it's important to see both things that are reported by parents as well as things observed by professionals. So this case history form gives a place to find all of those reported behaviors that we can be looking for as we start our observations.
Okay, Andrew's specific case history information that we pulled out, he did have prenatal drug exposure. He was born at three weeks premature via C-section. He had early neglect by his biological parents, and his father passed away. He was adopted by his grandparents. He currently has a strained relationship with his grandfather or adoptive dad. He calls him dad.
Mm-hmm.
And he's recently began having some contact with his biological mom.
And so what that tells you is that he has a history of trauma, but he's also got some ongoing trauma in his profile as well.
Other professionals, he was diagnosed at 4 years old with ADHD and ODD. He was diagnosed at 7 with mixed receptive expressive language disorder and dyslexia. He's transferred between multiple schools due to behavioral concerns. So he's kind of floated around a little bit from one school to another.
Including some homeschooling. He's been in and out. It's been very difficult, and he's 8 years old. So you can see how many times he's changed schools and how that might impact him.
So little still. His school psychologist reported EF deficits, but then they weren't targeted in the IEP. So they've been identified, but not something that they're working on in school. So the key findings or key takeaways from the etiology: he has significant trauma history with ongoing triggers, as Beth said. He has emotional and behavioral dysregulation, which is why he's been, kicked out of schools and moving around quite a bit. And there's been a failure to target his EF skills. Instead, they've diagnosed him with ODD and aren't really treating the EF issues. So when Andrew came to our clinic, we knew he had a history of developmental trauma. We knew he had ongoing trauma or ACEs. And so one of the things that we wanted to look at were these dysregulated behaviors. So we have this fight, flight, freeze, and fawn profile, which are the significant dysregulated behaviors that we have created. And so we have a presentation actually on speechtherapypd.com on the coping framework. So if you want to know more about this and hear more about this, you can go to that presentation. But we use this profile to determine which of these dysregulated behaviors that the client uses the most. We want to figure out what are their primary dysregulated behaviors that they're showing. So this was done on Andrew during a 45-minute session, and his clinician did it. We only had one rater for this child. We like to have at least 2 or 3 raters if possible, school teachers, parents, and then you as the SLP. And if the child's able to do it, we like to get their input as well. It's really important to try to get a team approach to this. We didn't get into the school with him to do this with the teacher, so this was just done in our university clinic. So you can see little tally marks next to the behaviors that he showed. And keep in mind, this was during one session, so a 45-minute session here at our clinic. He showed primarily fight and flight behaviors. So if you see that he has several tally marks on lots of different fight kind of behaviors, such as being disrespectful, he was argumentative, unable to follow rules, he was controlling, lots of excess moving, inflexible. Those are just a few. And then flight, he's hyperactive, he was silly, used some baby talk, was aggressive or threatening, does some running away. That's also in his history, and crying and silly voices. So those 2 showed up as his primary dysregulated behaviors. So we'd like to then put that together and figure out, okay, what is his profile? His profile is both fight and flight because he uses those behaviors the most. I don't know if did he have any freeze and fawn, or they just didn't show up very significant?
He actually doesn't have any freeze and fawn, or he did not in our 45-minute session. He does not show many freeze or fawn behaviors.
So, excuse me, his key findings from his assessment, his emotional and behavioral dysregulation, secondary to developmental trauma. So that's his diagnosis. He has a hybrid profile of fight and flight. He also has executive function deficits as indicated by the brief and the BADS. And some of his issues include inhibition, self-monitoring, shifting, emotional control, initiation, planning, organization, task monitoring, and flight behaviors during tasks. During the BADS, he had a hard time paying attention. So he had a lot of attention issues during those subtests. So that's a little bit about his background and his assessment information. So this is the point in our case study where we go to what are the impact areas. So Andrew is Beth's current client. So I'm going to ask her these questions and see what she thinks about what's impacting him the most. So the first area is auditory comprehension.
Not a concern.
Okay. How about oral expression?
Not a concern. He expresses himself too well.
EF cognitive.
A concern.
Speech.
No.
Social.
Yes.
Behavior.
Yes.
Sensory.
Yes, a little bit. It's not a primary concern that we're writing goals for, but some reported things with sensory have been there. Yes.
Okay. Written expression.
No.
And reading comprehension.
No.
Okay. So then our clinical questions related to those areas of impact. What impairments most impact daily functional?
I would say emotional and behavioral dysregulation throughout the day are the primary concerns by everyone that is currently working with and serving Andrew.
So you're seeing those at home, at school, at our clinic?
Yes, we're seeing them in all environments and with all people at this point. However, I mean, we're starting to see some progress with having a little bit more control over those after is our third, I think it's our third semester with him.
Yes.
Yeah.
What activities are most important for the client?
Finding some consistency in academics. He is not consistent in participating. So therefore he is falling behind academically, and he's a very smart kid. So we really need to find a way for him to consistently participate in an academic setting.
And his participation is impacted because of his dysregulated behaviors,
Yes.
primarily?
Yes. And I think also just a lack of understanding and interpretation of those behaviors by teachers and, other people in the school.
So that leads us to this one. What current characteristics hinder the client the most?
His dysregulation, and also I would say his limited awareness of his dysregulation. Awareness and then also education. He's just beginning to have some idea about this is not I'm bad, this is dysregulation. But that is very, very limited at this point.
And what current characteristics are strengths to build on?
He's smart. He has a curious mind. He really loves hands-on activities. And I would say he has some emergence of awareness of his dysregulated behaviors. And he is very, very socially motivated. He does not get much of a chance to do social activities because of his behavior. He doesn't earn social interaction. Here in our clinic, he gets to do some things with other clients, and it is the highlight of his week. And his dysregulated behaviors during those social times here in a structured environment are usually 0.
That's interesting.
Compared to like 45 to 50 when he's not. So he is very socially motivated. All of those things are definitely strengths for him.
Okay, so now moving into intervention.
Okay, so we base our intervention on what we call the coping framework. This is how we choose our goals, and everything always starts with that case history review. So this coping framework we kind of developed a couple of years ago, and we are continuing to develop as we use it with multiple clients and try to get a little bit more experience. But it begins with the case history review, which is the C, and then we really want to observe those behaviors for ourselves. We take our observations and we profile those behaviors. And then moving into intervention, we want to identify the behaviors in action with the client and then name them or label them. We want to use the vocabulary, fight, flight, freeze, fawn. We want to say, you're being controlling, you're being silly. We want to use that vocabulary. So we really, in our treatment, think about identification and naming specifically in the moment, in real time, the behaviors that we see. And then also we want to practice and get lots of practice with co-regulation strategies that we have matched to the fight, flight, freeze, fawn categories. So if they are primarily fight and flight, we have a list of strategies matched to fight and flight that we like to trial and then practice using those. We're typically at a co-regulation because they have no idea how to self-regulate, with the end, final outcome being self-regulation. But gosh, sometimes I still need co-regulation when I'm having a moment. So that is kind of, in the future, we start with co-regulation. Also, I think it's just important to, remind yourself that children with a history of adverse childhood experiences or ACEs display behaviors that are often misinterpreted. I would say this is one of our biggest barriers is that people see their behaviors as naughty or bad behavior that they have control over, and they're making bad choices. This is not the case for kids who are being triggered by memories of something that happened in their past. Their dysregulated behaviors are actually a survival response to something that they are remembering in a moment during the day, or something that happened in the morning that is triggering them later in the afternoon, and they have a survival response, a defense mechanism. Again, you can kind of say we all have that defense mechanism, and we kind of maybe act poorly in a moment where we are feeling defensive about something. It's at a completely different level for these kids, but I think it's a good way or a good analogy to think about. Fight, flight, freeze, and fawn are the dysregulated behaviors or responses to their environment, a situation, or an expectation at any given time due to trauma. I also like to say at this point that our diagnosis is difficult because developmental trauma is not in the DSM-5. They've been trying to get it in the DSM-5 for many years. However, the closest thing that we have right now is complex PTSD. And so we often will use that, but clinically, I still will say whatever the diagnosis is, maybe executive dysfunction, maybe language processing, but then I will say secondary to developmental trauma or adverse childhood experiences. That's how I would write it in a report. If a child is demonstrating a dysregulated behavior, then we need to know that the child is not learning. If we have, most of our clients are dysregulated for, 75 to 80% of their day. If they're in a classroom environment and they are dysregulated, they are missing the majority of what they are being taught. That's where that inconsistency comes in, where teachers say, he could just do it yesterday, so he's just not trying. Or the parents say, when he gets home, he has no idea what this paper is, and I know he saw it at school. And I'm saying to the parents, yeah, he may have seen it at school, but he has no idea what the expectations are because he was probably dysregulated, and therefore he has no idea what to do with this paper. A lot of times it's misinterpreted or misrepresented by people thinking it's memory problems or even attention problems. You saw that he has a diagnosis of ODD. There's a lot of misdiagnosis that goes along with developmental trauma as well. So individuals working with these kids really need to be able to recognize, not only recognize the behaviors as dysregulated, but understand why they are having the behaviors. If you don't understand this, appropriate treatment or appropriate intervention is just not going to happen.
Right.
And you're going to be working on the wrong things. Take my example of memory. If you think that this is a memory problem and you start working on memory, you're wasting your time because it's not a memory problem. It's a regulation problem. A client needs to be regulated so that they can learn. This kid and a lot of the kids that have developmental trauma have the ability. They have, age appropriate skills with regards to language. They're typically very bright, very smart. With even some additional street smarts sometimes that other kids don't have, but they certainly cannot perform up to their ability in the classroom.
Teachers are seeing, they are trying to manage an entire classroom. You have to give them credit for that. And these behaviors, especially the fight and the flight, are going to be very disruptive to the classroom.
You're so right.
But understanding why they're happening is really important. And so, we get to dig into the case history here in our clinic because we require that for all new clients. If you're working in a school, I think that's something that you have to definitely ask about and look for. And you might have indicators, they might be with a foster family or whatever. Let your social worker dig in a little bit more to that. And if you see that, you have to consider then, is their behavior because they're being naughty or bad, or is it a neurological trauma response?
Absolutely.
And like Beth said, the treatment for that is different. So regular behavior intervention, reward, punishment is not going to be effective for them. And we need to think about, well, what are the treatment strategies for their specific dysregulated behavior?
And then I think you're asking yourself right now, who is supposed to do this?
Is it your job as SLPs?
I'm working on some resources right now and really taking some research and evidence from the World Health Organization as well as ASHA, saying that this is what we do. If they are dysregulated, they are having problems with communication. and definitely with academics. So, I mean, that is what we do. It's just very hard. You can't do it alone. And so you can't be the only one. She mentioned that fight and flight are very obvious in a classroom and they're very disruptive. The other problem is that freeze and fawn are not recognized by teachers because typically freeze and fawn behaviors are kids who are they're disrupted here,
Yeah.
but they are not outwardly bothering anyone. So they're quiet. So they're just sitting, they're zoned out, they're spacing out, they're not focused, but they're not bothering anyone. So the teacher's like, I'm just going to let that go for the moment. However, they're still dysregulated and not learning. So there's a lot to unpack here. We just are touching a few of the key points as we move through. So what does intervention actually look like? I've divided this for Andrew up into the three sections that we're really focusing on. We're focusing on regulation, we're focusing on EF, and we're focusing on some reasoning skills. Again, you can see that all three of those things are very necessary for age-appropriate communication as well as being successful in a classroom. So starting with regulation, which is the one that I think would be the most difficult for you to kind of know where to start if you haven't had this experience. We have a long-term goal of just decreasing the frequency of dysregulated behaviors so that he can have a functional outcome of being more successful in the classroom as well as having better quality of life at home and with peers. Because right now there's a lot of stress and a lot of tension on the family dynamic. And so it's really important that we work on decreasing these dysregulated behaviors. And how do we do that? One of our goals is given a prompt, he's going to match the name of the observed dysregulated behavior on a fight or flight kind of label with 90% accuracy. Andrew's a client who literally, I mentioned this earlier, but I don't know if you caught kind of how many dysregulated behaviors we have. He might have upwards of 40 dysregulated behaviors in a 45-minute session, which seems almost impossible. How can you have one per minute? But he can, and he has. And so it's really important that we try to get those dysregulated behaviors to, below a certain level so that we can benefit and be productive in our sessions. Given a prompt, the client will initiate the use of a co-regulation strategy with 90% accuracy. I mentioned to you that every time he has a dysregulated behavior, it just spirals out of control because he doesn't know how to self-regulate. So it requires a prompt from the clinician to say, okay, stop. What can we do to try and get you regulated? If we let it go, we're going to be up to that 40 or 50 dysregulated behaviors. We need to put a stop to it, and we need to help him with a co-regulation strategy. I have a list of some co-regulation strategies to show you later in the presentation. A third goal is the client will independently use the emotion words to describe how he is feeling with 90% accuracy. He just doesn't really have a lot of experience with labeling his feelings. We've got several videos to share, and you're going to get to see him working on that skill in the videos. Okay, this very first video is Andrew working on naming some behaviors. Of course, I just like to mention too that we talked to Andrew's mom to ask her permission for sharing the videos, and wanted to know how she thought he would feel about that and how she felt about that. And she made it very clear that we could share anything we wanted because she knew how much people need this education. So just so you're clear on that, because that can be a little bit tricky. With foster kids, whatever, this is family, he's been adopted, it's all good. So this first video is him naming some behaviors. Okay, naming behaviors. What you're going to see is me naming some behaviors. This client was getting a little bit too mouthy, and the clinician was not quite being direct enough. And so I wanted to come in and model that. So here is a video of that. I'm actually seeing disrespect.
That too.
And disrespect is actually in the fight.
911.
I think you're being disrespectful with your interruptions and with your sound effects. You're being disrespectful. So when you're disrespectful, it means that you're dysregulated. It doesn't mean that you're bad. It doesn't mean that you're mean or even rude. It means that you are in fight or flight and you need to get yourself regulated. I like the way you're trying right now with being quiet and working hard. Okay, so what I like about this video are a couple of examples here. He was getting out of control. He needed someone to step in and kind of be direct and kind of interrupt the dysregulation. Sometimes it feels a little harsh to kind of name those behaviors and use specific vocabulary, but we've trained him for this kind of. We've let him know, we've educated him on the fact that we're going to be using specific vocabulary, and he knows what it means when we say fight mode. And we went through some difficult times with calling it that. He did not like it, but now he's in a place where he can kind of accept that. And it's really important to say that to him, primarily so we can make the differentiation between what I said. You're not being bad. You're being dysregulated. And so I want to help you become regulated. So that's kind of an example of what identifying what is actually happening and then also naming the behaviors would look like.
I love, love, love that you say that. And I think when we watch this together, I'm like, oh, I have goosebumps right now, because I think it's so important for these kids to hear about you're not bad. You're not bad. You're having this response. Your body is having this response to whatever is going on in the environment, and it's hard to control it. And we understand that. That's different than somebody telling you you're bad. And I just think how important that is for kids to hear over and over and over again. And I also know how much education that you've done with this client specifically on that concept.
And I can tell, I know him well enough now that he's really listening. He's really listening to what I'm saying, and he appreciates that I'm telling him that. So I actually see. Okay, another example of kind of this whole identifying and labeling. So this is an activity where we're showing him a behavior or a response on a piece of paper, and then he has to say what he would actually do, and then what he could do differently.
Oh, really? Okay, let's try another one.
You forgot your homework.
What would you do if you forgot your homework? If you were in class and Mrs. Cooper was coming around and
It'd be embarrassing,
homework.
so I'm gonna do flight because it's embarrassing.
What you just said. Instead of running away because you're embarrassed, what could you do?
Raise my hand and say, I forgot to bring my homework. I didn't mean to. I just forgot because I was doing something I was not supposed to. I forgot my homework.
Okay. So you told the
Truth.
That's right. That's right. Good.
Oh, wish.
Is that better than running away?
You're like.
Yeah, because what does that accomplish?
And out the door he goes. Okay, we also have had a lot of issue with him telling tall tales. So we, with some discussion in our meetings, the clinician made a truth meter. So it goes from this is a full-on lie to this is kind of an exaggeration of what actually happened. This is just a silly version of what happened. This is kind of true. I'm getting closer to the truth, and this is the truth. He really needed to understand how important it was for us to know where he was in lie or truth. He often would come and say, I went to the principal's office 6 times today. And we're like, is that an exaggeration of how you're feeling? Is that a full-on lie? Is it almost the truth? You went 5 times, but not 6. So we developed this visual for him that has been really, really beneficial. And you heard him use the vocabulary. You heard him use all the vocabulary. I'm in flight. It would be embarrassing. You heard the emotion. And then he was also able to come up with a better alternative.
Now, is that one you practiced or did he come up with that on his own?
He came up with that on his own.
Fantastic.
Oh, really?
Okay, another example of some alternative responses.
That's okay. Okay, what's this one? Let's think
Okay,
about
that would be outside, so I would probably punch the wall
the wall.
at this point.
Okay. Before you throw that, what could you do instead? What would be a better way to deal with that?
Go ask him to play.
Yes, good.
But that would still be flight.
I
not
don't
fight,
think so.
Fight because I would be mad. But I think it's
Okay.
either.
That's what I'm saying. You think so? You think asking them to play? What if they still say no?
Oops.
What would you do then?
Run off. That's
So that's flight. Okay. So if they still said no after you asked, what could you do instead?
okay. I'll play with you tomorrow.
You could say that, right? Wouldn't that be better?
I'm ready for another one.
Good.
Okay, so in that example, the piece of paper said, what would you do if you asked someone to play and they said no? And his first response was, I'd probably punch something. And I can tell you that that's probably what actually would happen in that moment. And then he was supposed to go put the paper in fight mode, knowing that he was in fight mode. I mean, he knew exactly where that was going. And then his clinician said, what would you do instead? He had a really hard time coming up with an appropriate answer for that. They really had to kind of keep working at that. And I think that that even requires a little bit more work on some role playing on what would you actually say? And is that really, is that really something you would say? But I think it's all moving in the right direction. And he still said, even if I said that, it might still be flight mode. That's maybe, do I think that's better than fight? I mean, I still would be dysregulated. I just think it brings about, look at how thoughtful he's being. I mean, he's really participating. He's trying to understand his emotions and recognizing his dysregulation. Okay. An example of what to do when you feel dysregulated.
Okay, so what can I do? What can you do, right? These are things that you can do if you're upset. All of these. In fact, I'm going to let you take this home today, okay? So instead of kicking, instead of hitting, instead of running away, these are all things that are going to help you get regulated.
Or before I think about it anyways, I should wait 10 seconds and think about it.
Exactly.
I just like the video example of him having a conversation about it. I also like the way the clinician says, there are lots of options of things that you can do when you're feeling dysregulated. You need to stop and think before you act in dysregulation. Is there something I can do to help keep me calm? He has a stuffed animal. I think a couple times you've heard Bailey, and you may hear it another time in a video. He has a stuffed animal that he often brings with him that really we've found that it's very regulating for him to have his dog Bailey with us in the sessions. And he will request it. He'll ask for it. So just trying to get practice with some of these strategies that we've identified that might work, and him expressing it, him talking about it, kind of talking through it, those things are going to be really beneficial. And just look at the connection. One of the biggest.
I was going to comment on that.
Oh, yeah.
Just him when he looked at the clinician, like he's listening and he's invested, I feel like, in this conversation.
And one of the biggest things that you can do with these clients that a classroom teacher has a difficult time doing sometimes is really allowing the trust and the connection to kind of be the first priority. I mean, this this took time to develop. I will admit that this has been a very, very successful semester. They have made a very quick connection, and it's paying off. You know, our clients switch clinicians every semester, but I also think that's important for him to have another person to connect with.
Mhm.
So
Tell me about, so the clinician's like, I'm going to send this home with you. And we know that education for parents is a big part of it, because what you're doing in therapy for only a few minutes, you know, well, we have 4 to 5 minutes twice a week, which is a lot. But how does this translate to the family, and what kind of communication and conversations have you had with them?
yeah, not easy actually. You read in the case history that he has a little bit of a strained relationship with his dad. And dad is the one who brings him to all of the therapy sessions. Mom works, so she's not able to bring him to the sessions. We communicate with her, I would say bi-weekly via email, and we share things with dad while he's here. He's not as receptive as we would like, but I feel like it's another one of those situations where it takes kind of time to build the rapport so that he will be more receptive to what we have to say. Just last week or the week before, Andrew was having a very difficult day, and he asked if dad could come into the session. And so the clinician went out to ask dad if he would come back into the room with him. And we were like, oh my gosh, this is going to be a great opportunity to model some of these things with dad. You know, it was uncomfortable for dad. He wasn't as comfortable as we had hoped with being in the session. That was the first time that's ever happened. So I'm actually not surprised, but I think it was a good first step. Andrew really wanted him to be part of the session, and he was a little bit reserved in doing that. And so it wasn't as successful, but it was a first step.
And I think in your experience too, you found that you can't just educate one time. Like this
Oh, yeah.
education have to happen over and over and over just to enhance the understanding.
Yeah.
Right? It's really hard to accept that these behaviors that you see are not because the clients, your child is being bad, and to
Right.
understanding why they're doing it. And it takes a lot of self-control, I think, as whether you're the clinician or the parent, to inhibit what you would normally do for
Yeah.
behavior and instead employ one of these, you know, regulation strategies that you're going to talk about here.
And I think if you are working in a school district, you don't have access to parents to do some of this education. I'm going to guess you're going to need to do the same kind of education with teachers in the classroom, because they're going to be coming from a very similar, you know, place where they're
Mhm.
just not quite recognizing it. They are frustrated. They don't have time to like really stop and kind of deal with some of these things. She mentioned early on that discipline is very different with these kids. A lot of times, you know, these kids are placed into a behavior classroom where there is one kind of discipline or reinforcement practice where kids have to earn things. Earning rewards or earning privileges for kids with trauma is very counterproductive. So, you know, the education is not just with parents, but you as the SLP in that school district need to be that kind of, you know, connection to the teacher by saying, I know this is so frustrating. Believe me, I felt it when I'm with him one-on-one, but let me remind you kind of what we're looking at. And it is hard when you have a classroom full of kids and maybe 2 or 3 of these kids with trauma responses. It can be very overwhelming. You know, be that person for them to be that teacher's co-regulation and help them kind of through that. And you'll have to do it multiple times.
Yes.
Okay, here is an example of matching behavior responses to strategies. If you look on the floor, you can see that we have some different regulation strategies. My favorite is the little, what is it, magnetile type thing. When he comes in, it's one of his choices for kind of a mindfulness task. So right when he comes in, we like to have him do a 5-minute mindfulness task, no talking, just to kind of regulate himself to get ready to learn. It is one of the things that is somewhat successful with him. He does like it. You can also see a regulation thermometer on the floor, a visual. It goes from green, to red, saying in the green section, I'm feeling ready to work. We often call a regulated brain a working brain. My brain is working. It's ready to hear what you have to say. It's ready to learn. And we call a dysregulated brain, sometimes we call it stormy. Sometimes we call it offline. Sometimes we call it a not learning brain. So you might have a learning brain and a not learning brain. Really, those things are very client specific, and you need to find something that makes sense to your client. So we often will say to him, you were a 7, and I can see that you're now coming down. You're at a 5. You're getting close to being able to work, but you're not quite there yet. Let's keep working on some regulation things. Or we might say something like, you were at a 5, and look, now you're at a 2. You are ready to go. So you can see some of those things scattered around. It looks like it was a little bit of a hectic day. Okay, let's hear some matching feelings to strategies.
How does this girl look?
And wait, is that Bailey?
Could be.
She's sad and she's holding my pet Bailey right
How
now.
could you tell that she's sad?
Because she's going, wow, a baby.
Oh, and so that means she's sad. What could she do to be not sad? She could
Cuddle with Bailey. Yes.
So when you're sad, what could you do?
Cuddle with Bailey.
That's right. Do you do that sometimes?
Yeah.
Okay, so it is one of his favorite things to do is to cuddle with Bailey. I think this kind of therapy with emotions and feeling words and how do you know, I mean, those feel a little bit more like something that you're familiar with in speech and language therapy. But I think those things translate really well with our kids with dysregulation as well. This is an example of kind of a worksheet that we use for practicing regulation strategies. So I've got a list of co-regulation strategies that are commonly associated with fight mode on the left and with flight mode on the right. What you need to do is trial and error multiple times. So the way we have kind of this worksheet set up is, I've identified a few that I think have worked for him in the past, but I want to know how much of a positive impact those strategies have on him over multiple trials. So, I may say today in therapy, when he has some dysregulation, I'm going to really try deep breathing, and I'm going to really try the stuffed animal, his dog Bailey. I'm going to put a plus if I feel like it's making an impact. I'm going to put a minus if there's really no impact. And then I want to track that data to see what might be working. You'll see some specific things on there, like fix it. That just happens to be one that he was doing. We were giving him a task to do in the session, thinking that it would help him with his fight behavior. And he started messing with our blinds. And the next thing you know, he's like, there's something wrong with this one. I need to get up. I need to stand up on the window sill and fix that blind. And he did that for about 5 minutes, very focused in his fixing. And when he got down, we could look at his emotional regulation thermometer, and he was ready to work. Now we know that he really liked fixing things. So there are times when he is dysregulated that we say, hey, this is broken. Can you put new batteries in it? Hey, this is broken. Do you have any way of screwing that back on there? So sometimes you'll notice some that you want to be very specific. It's kind of a starting point for regulation strategies. High-level language or reasoning kinds of activities that happen in that frontal lobe are another really important client-specific intervention for kids with dysregulation. We know that they often don't ever get to that frontal lobe use because they're functioning and kind of stuck in that primitive brain survival mode. So they need lots of practice there. So we do have some goals for Andrew in reasoning, for daily behavioral decision making. We really want him to think before acting. So one of our goals is to target a specific scenario that we give him and have him state the impact that the action will have on all the people involved. Really important for him to think about how his behaviors, dysregulated responses, are making other people feel. One of the best ways that we have worked on that is some role playing where the clinician will take on the role as Andrew, and Andrew will take on the role as the teacher, and he'll be trying to give instructions to new Andrew on how to do something, and the clinician will be acting out with all kinds of dysregulated behaviors. And it's really interesting to kind of see Andrew be like, what are you doing? I mean, why are you acting like that? And then they have conversations about how much of an impact is this? We're not going to be able to finish this activity. How do you feel? Do you feel like I'm paying attention to you? Do you feel like I'm being disrespectful? We use, again, some of that vocabulary. We also use labeling the level of impact of the given action. So we really want to know, do you think this is a big problem, a medium problem, or a huge problem? Listen, we have to really learn with these kids to not sweat the small stuff and to let some things go. But we need to really talk about what's the severity level of these problems? And then also the consequence that might need to happen if it is a severe problem. So here is an example of practicing labeling impact and consequence.
Look at all those visuals on the table.
Let's see. I think the one with the pyramid is, am I listening? I think it's a listening one. We talk about I'm all ears, ready to listen, or my body says I'm not listening. It's kind of a pyramid hierarchy of that. I see some strategies here at the front of the table. You can see Bailey sitting next to him in the chair. He's also on a wiggle seat to help a little bit with his focus. And then you'll hear what this visual is that they're using.
Consequence. Okay, you ready? Let's say you miss the bus. Who's the problem for?
Me? It's
Okay.
tiny.
You think that's a tiny problem?
A big problem.
Okay, let's see. What's it say?
It could put someone in danger.
Maybe not. Okay, so
It could feel hurt. It could kind of hurt someone for their feelings.
I think
Yeah.
maybe it might be a medium problem. You think so?
How big is the consequence? Not really in trouble.
Okay, so our problem was what size?
In some trouble,
Okay, so we had
It's not their fault because the bus did it. And
Oh,
scared.
really? What if the bus was on time but you were late?
Oh, that'd be in the most trouble you can think of.
Okay, he doesn't have a good gauge of how big of a problem or impact it is. He goes straight to it's the worst ever. And you see on the you maybe can't see, but you heard him say, when you rate the problems, it's like, is someone in danger? I mean, that's a severe problem. Or, is this something that I can, now that I know it's a problem, I can just do it now, do it later, whatever. And then also, what kind of trouble are you going to be in on the bottom of that? So 3 really important things. What's the problem? Who's the problem for? How significant is this problem? And then what's the consequence? I mean, that is some really important information to have when you're trying to do some of that differential discipline. I think you need to kind of think about that and then use that same vocabulary. Again, sharing this with educators who are working with him is something that really needs to happen. They need to know.
I love to hear him use the vocabulary too.
Yeah,
I mean, I
me
know you guys
too.
have spent time on it, but clearly he's, you said that intellectual is a strength for him.
Yeah.
And he is comprehending things very well and using the terminology, which is great.
I know. It's so interesting to watch.
Consequence.
Okay, and then also executive dysfunction is a very common set of goals with these kids. So a long-term goal might say improve executive functions to promote the completion of daily activities. We really do work on inhibiting action versus just blurting out impulsive responses. So we literally set a timer, and the timer is only 10 seconds and it feels like an eternity. And so he is sitting, we give him a question and he has to wait to answer for 10 seconds. This is very difficult for him, but really important. Also, improving self-advocacy by independently initiating, requesting help or clarification. Don't just zone out and think we're going to ignore you. You need to say, I missed that. I was dysregulated. I missed that. Can you say it again? So we really work on self-advocacy skills. And then also ability to shift between rules. When we gave him the BADS, he actually was very good at some of the skills on the BADS because they were very hands-on, kind of like that whole fix-it idea. But when we did the 6-part tests where he had to shift between, and so the card test where you have to shift between rules, I mean, he couldn't do it at all. He could not inhibit the rule he was doing to shift to a new rule. I mean, think about a classroom all day. You're shifting between activities, you're shifting between instruction. So very, very difficult for him. And he becomes very overwhelmed and then very dysregulated. Okay, this video is the last video, I think. This is a little bit about self-identification of what's happening and self-advocacy. You know, we've been working on inhibiting, and you're going to hear a little bit of his own personal analysis of this task. We might even watch this one twice because it's just super impactful. He had been really struggling, a little bit tearful, and here is the conversation.
Okay, but when you were in the moment here, right?
Yeah.
Did you know that you were sad? Did you feel that you were angry?
Not really.
Interesting.
I just let all the anger.
That's
I
right.
should have stopped and thanked and then speak.
Please give me a high five. That's incredible.
That's incredible. Okay, what's been really beneficial with self-advocacy and self-identification is video modeling. I don't really mean video modeling. I mean video analysis. So we record our sessions and then we pull pieces in for him to watch. So on days where he is out of control, disrespectful, argumentative, whatever it might be, we bring clips in and we have him watch it. And we say, what do you see? What do you think you were feeling in that moment? And then can you hear it one more time? I want you to hear what he says one more time.
Okay, but when you were in the moment here, right?
Yeah.
Did you know that you were sad? Did you feel that you were angry?
Not really.
Interesting.
I just let all the anger.
That's
I
right.
should have stopped and thanked and then speak.
Please give me a high five. That's incredible.
I also love the acknowledgement from the clinician. The clinician is acknowledging that is really interesting that you're telling me that you didn't know. I mean, I'm listening to you. I hear you saying that. Acknowledgement is really important in this therapy as well. So that clip right there just happened, I believe, last week, and it wasn't going to be in the presentation. And the clinician's like, it's got to be in there. It was so good. It's such a big turning point for him. Okay, wrapping up here on regulation or methods, I guess. I want to talk about methods. So, you know, regulation methods need to really be part of what you're doing. You need to kind of have a set list of possible co-regulation strategies that you want to embed into your sessions when you see a specific dysregulated behavior. We've talked a lot about education. It's really awareness training to both parents and educators. They have to have awareness and understanding of the cause of the behaviors, the triggers of the behaviors, and just to recognize that this is a survival response, not bad behavior. Collaboration, consistent collaboration with all involved. What's working? What's not working? Get involved if they have counseling somewhere else. Make sure that you're using the same vocabulary and terminology. You will learn a lot from the counselors on what they're saying and what's working for them. Also visuals. You saw all the visuals for reasoning and executive function skills. The videos for self-identifying, I think they don't know what's happening in the moment because they are dysregulated. But when they go back and watch it, they can really reflect on it and learn so much from that. So that's very important in your methods. Make sure to include it. There's lots of research out there on using video review. And then role playing. We do a lot of role playing with Andrew as well, and also a lot of evidence out there on using role playing for real life, functional, in the moment kind of identification and practice. Two of the best resources I have. One is Beacon House Therapeutic Services. You can find it at beaconhouse.org. This is how it all started for me, was me finding Beacon House and all of their amazing resources online. Also Babyfold in your area. If you are in Illinois, we have Babyfold. I just had an IEP meeting yesterday, and a Babyfold representative attended that meeting as well. And then this book by Pete Walker. That's how I found a lot of my dysregulated behaviors, and it helped me with profiling, finding the dominant profile, finding the hybrid profiles. Every time I read it now, based on experience that I have, I see something new that I want to add. But that book is very, very useful. It's almost like a toolbox for individuals, but you can also be the facilitator of some of those strategies as well.
So take a picture of that because that one's not in the handout.
Snap, you got it. It's a good one.
Okay, we better answer some questions.
Okay,
Just we've got our socials here and our teachers pay teachers. As Beth and I said, we are working on other resources and trying to pull this together in a big resource book. So if you're watching this post 2025, look on our website because we hope to have things available there. And also, like I said, our coping framework presentation that's on speechtherapypd.com if you want some more information about that. Questions.
And then also we will be at ASHA. This again, 2025. We will be at ASHA. Did you already say that while
No,
I
I
was
didn't.
looking? And we will be with the Speech Therapy PD booth. So come and find us, and we're going to have our resources. A lot of these things will be ready to share at the resources at the booth, that we can share those with you and tell you how you might be able to get them and use them for yourself.
And we'll be there for a meet and greet on the Thursday morning. Okay, questions. We better get to it.
Let's see. The school psychologist needs to be involved as well.
100%.
Absolutely. And again, I went to a meeting yesterday, and the school psychologist was not part of that meeting. And that is definitely a must. We need to be better about making sure that they're aware.
Can this model be used or adapted with students with lower cognition too? Absolutely. And younger kids. You've worked with a little
3-year-old
using
and
the
use
terminology.
the terminology, and it works. Yes. Let's see. You're welcome.
What resources would you share with a school psychologist?
I would share that Pete Walker book. It has a lot of information about dissociation and different profiles that are more probably school psych than even speech and language. So that book for sure, and the Beacon House resources as well.
And if a BCBA does not agree with using trauma-informed strategies, what suggestions do we have? I think it's all about understanding those dysregulated behaviors. They have to read about it. That book and the Beacon House has great, I feel like, things for parents. It's very easy to understand, don't you think, on the Beacon
Well, and
House?
I mean, I would need rationale for why they're saying they disagree with that. I mean, I would need rationale for why they're saying that. That would be difficult for me to handle. I think there's a similar question for occupational therapy, not that they disagree, but would you co-treat with OT to find dysregulation strategies? Yes. However, you need to know that there are 3 different kinds of dysregulation. There's emotional dysregulation that is typically associated with trauma. There's behavioral regulation that is typically more related to like ADHD or mental health. And then there is sensory dysregulation, which is usually more associated with your kids with autism. So, they may be saying, I can do some sensory regulation, but really where we need to be is that emotional regulation. So you need to be clear on those differences. However, I certainly would want them involved and think they could be helpful.
Are you not so glad that somebody asked that question? 'Cause
I
we
know.
love to talk about
I love to talk about that.
different.
I don't
strengths
like
of
this
behavior.
regulation being used as an umbrella
Umbrella.
term. I feel like there are different regulation, and it's all about the cause, right?
And then finding the right strategies, because all the strategies are different.
That's right.
Always got to go back to the why. Why is it happening so that your intervention matches?
Okay, we are probably a couple of minutes over now. Any other specific questions that we need to address? I think a lot of similar things here.
And Beth and I have talked about there's a difference from, there's a difference in being trauma informed and knowing what to do in your practice.
Yeah.
Right. And I feel like it's one thing to know about it and recognize that it's a thing, but it's a completely whole different beast to know what to do with it.
And I think that's the first step, right? Awareness is the first step. And I think that schools have done a good job of getting people in there to educate them on that this is happening, especially in a lot of the lower SES populations where there's a lot of these kids in the school. But I think it stops there, unfortunately, and people are not moving to the next level of them. What do I do? What do I do with them? A lot of times they're ending up in behavioral classrooms, which are just not the right fit for them. I don't have a good answer. I think we're going to quit our jobs. We're starting a developmental trauma school. Reach out to me. We'll let you know about that. So I don't have the answers. I don't know exactly where it's going to fit. And honestly, it depends on the person teaching them. It depends on the person. I was in an IEP meeting yesterday where the principal kept saying, well, it depends on who the teacher is. If it's this teacher, they could probably handle it. If it's that teacher, that's just not fair to the client. So, it just takes a lot of advocacy from you and probably a lot of fight from a parent. So, right.
Let's think. Anything else you want to say? I know we're a little bit over, but anything else you want to end with before we wrap things up?
I
had a little blip in the middle.
I know. I'm so sorry about that. I don't know. I'm just feeling a lot. I've got probably 4 kids on my caseload right now with trauma. I know these kids are out there. You're running into these kids, and you're probably in your head right now thinking, I need to reconsider what we're dealing with here. And it is something that is appropriate for SLPs to work on. Again, go to ASHA and look at the scope of practice. You will see some specific statements about why this is appropriate for SLPs to deal with. So get involved and share your knowledge. And you read a client better than anybody else. You make a connection with clients as the SLP better than a lot of people. So, help these kids.
And I'd say get connected with your social worker in your schools, because I think you guys can team up and really address this in 2 different angles.
Yeah. Good luck.
Okay, so that concludes our presentation for tonight. Thank you so much for joining us. We enjoyed presenting to you tonight and hope you had some great takeaways.
And we'll be back next month we have 2 epic case studies left.
Yep.
We look forward to seeing you. Come see us at ASHA.
Bye.